Good evening, everyone. Thank you for joining us this evening. We have a great and exciting program planned for you with two wonderful speakers. Let me just give you a few introduction slides to start. This is COVID Conversations. All lines are muted during the program. There is a question and answer box located at the bottom of your screen, and you can use that to ask any questions. This program will be recorded and will be available later on YouTube. If there you could see the question and answer box. Again, leave any questions there. Dr. Eric Ball and I will moderate and try to get as many questions answered as possible. A little bit about us. The California Immunization Coalition is a 501c3 nonprofit public-private partnership that's dedicated to achieving and maintaining full immunization protection for all Californians to promote health and prevent serious illness, disability, and death. We are also partnered with the AAP California, which is a partnership of the local California AAP chapters. The AAP California is committed to the attainment of optimal physical, mental, and social health and well-being of all infants, children, adolescents, and young adults living in California. So, just a quick introduction. I'm, again, Pia Pannaraj. I'm from the Children's Hospital of Los Angeles, and my co-moderator is Eric Ball, and he is with Children's Orange County Primary Care Network. Great. I'm going to turn it over to Eric.
So before we start with our panelists, we're going to try to set the scene today. So today we're going to be talking about pediatric vaccines, in particular, the rollout of vaccines from 0 to 5. But we also want to set the stage about where we are and where we're going in the state. And with that, we have a small presentation with two of our esteemed colleagues at the California Department of Public Health, Rob Schechter, who's the chief of the CDPH Immunization Branch. He's been a medical officer with CDPH since 2003, and he's a member of the American Academy of Pediatrics, a proud pediatrician. And Nisha Gandhi. Nisha is the Adult Immunization Coordinator at CDPH Immunization Branch, has been with the branch for over 20 years with a primary focus on adult immunizations, but she's also involved with the state flu program and has been involved heavily in the COVID-19 vaccine program, helping support provider enrollment and onboarding. And Dr. Schechter and Nisha are going to talk to us about what's going on with pediatric vaccines in California, and more importantly, how we can get more providers to start giving vaccines in their offices and their clinics. And with that, I'm going to turn this over to Rob and Nisha. Thank you.
Thank you, Dr. Ball and Dr. Pannaraj. Can you hear me okay?
Perfect.
Thank you. Good evening, everyone. And thanks for the opportunity to talk to you for a few minutes. Looking ahead to immunization for under 5s, to be able to look back at the last few months and see how things are going with the 5 to 11-year-olds, and then talk a bit about what's up ahead in vaccine, and again, as Dr. Ball mentioned, the need for additional pediatric care providers to help support the effort. Next slide, please. So the images here come from an infographic linked at the bottom of the slide that's also on the EZIZ website for VFC and other pediatric providers in California. And it lays out the case for why COVID-19 is a childhood illness, as you've certainly experienced over the last years. And as this slide indicates, that looking at the rate of coverage at 5 to 11-year-olds in California, since vaccine's been available for them since November, only about a third have received 1 or more doses statewide. Next slide, please. And if you look at the map by counties, there's a wide range of coverage. Within that average of about a third, the rates are as high as 3/4 or to 80%. And as low as below 5%. And even within the high rate counties, there's still a number of children who haven't been immunized and who could benefit from COVID-19 vaccine. Next slide, please. This is a similar figure looking at different classes or this equity quartiles, where the blue line are children who are most vulnerable in California, and the olive green line at top are the least vulnerable or most affluent children in the state, and showing a 30% gap between the haves and have-nots in coverage. So, and then again, if you look at even at the highest rates, it's still only about halfway there, and there's plenty of room for improvement for all of California's children that could be achieved. Next slide. So this is just knowing the concerns that there are many parents who are ambivalent or who are not interested in having their children vaccinated. This is a reminder. This is Kaiser Family Foundation survey data, with the top bar being from last month, January 22. And the purple bar around those two blue areas suggests that there's still up to a third of parents who currently now would be interested right away, or could be persuaded, are in the wait and see category. Another third of parents who are amenable to considering vaccination for their children. And then looking just to the right of that, in that lighter green, that category is only if required. And next slide, please. There are two pathways in California to an upcoming school requirement for children, either in the 7th to 12th grade group, the middle and high school group, or the primary school group, or both, depending on regulatory action on the federal level. So, but within the state, there's a pathway that the governor laid out last October, where through regulations, through the administration, that COVID-19 vaccine would be added to the list of required school vaccinations, conditional upon FDA approval, full approval of the BLA, the license application for the vaccine. So as the federal regulatory review of full licensure over the next months, then that would trigger a process in which vaccine could be required as soon as fall 22 for either the 7th through 12th grade span or the kindergarten through 6th grade span. In parallel to that track, as you may well be aware, Senator Richard Pan has introduced a bill that would also require COVID vaccine. So there's two parallel efforts going on right now. Next slide, please. So vaccine, as the headlines from the last week, the stop and go headlines from last week, vaccine is coming soon for children younger than 5, but where will they get it? Next slide, please. This pie chart shows for children 5 to 6 years old in California, up through a week or so ago, where have they been getting their doses of COVID vaccine? And you can see that the biggest slice is under medical practices, such as yours. And the next biggest slice has been pharmacies, with over a third of children in this 5 and 6 years olds getting it in pharmacies, and even a greater percentage as you get out to the 9, 10, and 11-year-olds. Next slide. The problem looking ahead to the under 5 group is that by federal law, state law, and corporate policy, pharmacists are unable to immunize children younger than 3 years old. So looking to the 6-month to 4-year group, which is the next group up for consideration, most of them will not be able to go to a pharmacy. And so who can fill in that gap? If pharmacies are having a diminished role, then hopefully medical practices and primary care settings can fill the gap, at least part of that gap. But looking at the 3,000 plus pediatricians and family physicians in California who participate in the Vaccine for Children's program, providing routine vaccines for Medi-Cal eligible and other vulnerable children, about half of them are either not enrolled currently as providers, or they are enrolled, but they haven't yet ordered any pediatric COVID vaccine. And these providers tend to be the smaller volume providers, but they still serve up to 1/3 of VFC eligible children statewide. Next slide, please. So we have pharmacies with a diminished role and many primary pediatric care providers needed to provide the same kind of robust network for care that is available for routine immunization. And thinking back to that Kaiser family slide, that there are many families that will need multiple conversations, multiple counseling to review information and address their questions and hesitancy. The optimal place would be the medical home and practices such as yours to deliver vaccine. We are aware that many practices have identified barriers, staffing or other barriers that are keeping them from participating, and want to work with you to address those barriers, want to increase the network, at the same time wondering how in the short term can bridge some of these gaps. Next slide. So these next few slides, for those of you who haven't enrolled yet, the My CA Vax homepage provides the portal for registration. These are some of an overview of the steps involved to get enrolled. If you are a routine pediatric provider, many of these you may already have under your belt in terms of participating in care or your local immunization information system, in terms of being familiar with storage and handling guidelines for the VFC program, and having looked at some of the training modules through EZIZ that the state provides. Next slide, please. These next two slides try to address some concerns we've heard over the last months. One is looking back to December 2020 and the need for ultra-low storage of COVID vaccine. But at this point, with additional information, COVID vaccines can be stored for months in your routine vaccine refrigerator. One is the volume, minimum volume, and how much storage capacity do you have in addition to your routine storage. And with the state's relationship with a redistributor, small practices can order as few as 30 doses at a time and can reorder those as frequently as weekly. Wastage. Many of you are responsibly handling your routine vaccines and worried about the 10-dose multi-dose vials. The operating principle there is don't miss opportunities to vaccinate, even if some doses in a vial aren't used. Next slide. Reimbursement may be a concern. California Medical Association has summarized a lot of vaccine reimbursement information on the linked quick guide and on their website. Liability, similar to routine vaccine being covered through the VICP, the Federal Vaccine Compensation Program. There is a parallel program for products under emergency use authorization called the CICP. And then we've frequently heard frustration about, I'm a VFC provider, why can't it all be consolidated under the VFC program? We would like that too at the time, but for the time being, there is there are two separate federal programs with two separate federal agreements to work through. I want to just close with some ways we're trying to support providers enroll and administer. One is an extension of a program last year that was called the CalVax Grant Program. This one's called the KidsVax Grant Program. And at least initially, as it opens in the next weeks, it's targeted towards those VFC providers who are serving those most vulnerable kids. And if you are in that category, could receive up to $10,000 for enrollment in the program. And then if you're already enrolled, or enroll, and then you could also proceed to expanding hours and qualifying for additional financial support to help extend hours. So please stay tuned for more information about this program. The website will be the same as the CalVax grant, but there's not information there on the website yet. Next slide. And this summarizes additional support resources for various aspects of being a COVID-19 vaccinator, and a combination of help desks and links and archived information. Next slide. Storage and handling guidelines, some links there to the Pfizer COVID vaccine and to the EZIZ website for storage and handling. Next slide. And I won't go through the details, but this summarizes some of the aspects of both the orange cap and the forthcoming maroon cap that will be for the under fives. The bullet points are the same for both formulations, 10-dose vials, 100-dose minimum orders initially from the state, but we'll be able to redistribute that through AmerisourceBergen down to 30 doses for small practices. You'll notice that Nisha was introduced but hasn't spoken, and I apologize for mansplaining all this stuff, and she is there to support us and to help answer questions that might come up. And thank you for your attention, and look forward to the conversation.
Wonderful. Thank you so much, Rob, Dr. Schechter, and Nisha for joining us this evening. I think as Cameron switches over the slide deck back to the introductions, I'll go ahead and introduce our two guest panelists today. Dr. Dean Blumberg, he is a professor and chief of pediatric infectious diseases at UC Davis Children's Hospital in Sacramento. He has provided expert testimony at numerous California legislative hearings and participated in national and international advocacy activities. And he's the co-creator and executive producer of Kids Considered podcast. So I suggest that you listen to that podcast sometime. In addition, we have Dr. Nava Yeganeh, who is a pediatric infectious disease specialist. She is currently at the Los Angeles County Department of Public Health, serving as the medical director for the Vaccine Preventable Disease Control Program. And she's also an associate professor of preventive medicine at UCLA. So thank you very much to both of you for being with us today. So I'll go ahead and launch into some questions for you. So as you know, we initially planned this COVID conversation to coincide with being able to talk about the FDA's decision on the 6-month to 4-year-old COVID vaccinations. Can you talk about what happened with the FDA's decision to hold their review?
Yeah, so the Pfizer vaccine, when they went down in age for that, in the small studies they did in the 6 months to 5 years of age, the small studies suggested that using 1/10 of the adult dose was the appropriate dose to achieve similar or better immune responses compared to older individuals that we knew that the vaccine worked. So that's commonly done in these vaccine studies. Immunobridging is what it's called. But what happened was for those 2 to 4-year-olds, the antibody response was not as good as it was in the older individuals, in the 5 to 11-year-olds or the 12 to 17-year-olds. And they didn't have enough cases to know if there was actual protection. So the first thing that they look at is the immune response. And they realized that they needed to get a better immune response. For those 6 months to 23 months of age, the immune response did look good. So it looks like they got the dose right. But that's actually why they have to do those studies, is because you want to prove that the vaccines are safe and effective. So, so back to the drawing board, and then there's 2 options you could do at that time. You could give an extra dose of vaccine, and instead of giving the first 2 doses 3 weeks apart, you could give a 3rd dose. Or you could change the dose, and the company decided to give a 3rd dose. Now, the FDA had requested Pfizer to present the data to them, but I'm not sure that it was feasible to do anything with that data without having the final data set, because I don't know that many parents would want to embark on a vaccine schedule when they don't know what the schedule is. They don't know what the endpoint is. So it wasn't really feasible. So I think they rethought that, and they realized that there wasn't much that they could do with that data in terms of forming firm conclusions at that point. And that's why they changed the timeline. So Pfizer says that they will have data soon. They anticipate at the beginning of April. And so we do expect them to present the data to the FDA at that time. If it does look good, if it's promising, the turnaround time then for the CDC to evaluate it and make recommendations, it's generally about a month. So maybe in May, we might have vaccine for the less than 5-year-olds. And in the meantime, Moderna is also doing studies in 2 to 5-year-olds, and they expect their data sometime in March. So, we're gonna get that data. We're gonna have that information. It's just gonna be another month or two.
My understanding in the original trial was that there actually was a robust immune response in the 6-month to 2-year-olds, but not in the 2 to 4-year-olds. Do you know if there's any consideration of actually rolling it out to that younger group and then holding it back for the older group?
I think that was a consideration, but gosh, I think that's just so awkward. And there's been so much confusion with the messaging with COVID and so much criticism of that I just think that's so awkward to have kind of a donut hole with those kids in between. And so I think, for public health messaging, it just makes sense to roll them all out at the same time.
Yeah, and I think there is, in general, when you're doing this type of trial, when you're doing de-escalation, you can't kind of skip age groups because they're looking at immunobridging, they're looking they're using a different sample size, and so in the initial trial design, there is this idea that you kind of have to go through this de-escalation through the ages. Similar with Moderna, I know many of us know that the Moderna vaccine for the 12 to 18-year-olds is being reviewed by the FDA. So they can't proceed with the next level until that's been appropriately evaluated and authorized.
Do you have suggestions for how we as providers and public health officials should communicate this change or this delay to the public so that we don't allow them to lose confidence in the vaccines for children in this age group?
Yeah, from my perspective, on the contrary, this instills confidence that the vaccine is not going to be rushed, that it will be evaluated, that we're going to make sure that we have complete safety and immunogenicity data. And that's why we do the study. So to me, I don't see it as a real setback. I see it as that's why we do the studies, that we wouldn't want to have an ineffective vaccine dose released for any age group. That's not what we're looking for. And so to me, it inspires more confidence. That's how I would communicate it.
Do you think there's a possibility that when the third dose data comes out, that there will not be a significant difference in protection between the control group and the intervention group? And I say that because the amount of COVID in the community has dropped precipitously recently. And I'm just wondering, maybe there won't be enough COVID to differentiate the two groups.
There might not be enough cases, and that at press conferences, they've stated that there are a few cases that they've seen. But I think the FDA can make these recommendations on the basis of the immunogenicity studies and follow up with the protection. And they've done that before. They've done that with HPV. They've done that with other vaccines. So I don't think that it's absolutely necessary to have the vaccine efficacy or effectiveness data. I think the immunobridging, even though we don't have an antibody correlate of immunity, if we get similar or better antibody responses in that age group, we would fully expect it to be protective.
And I do believe this is how the study was designed. That's what they were looking for, is that they achieve the same amount of immune response as the 16 to 25-year-olds. So as long as they have the same immune response, the vaccine should work in the same way.
What advice would you give parents in the meantime, especially as now the guidance mandates are changing? California is looking to unmask individuals and in public places. How do we keep those kids protected who can't get vaccinated yet?
Well, the second best way of protecting people, second to vaccine, is masking. And we know that kids can mask safely and effectively down to age 2 years of age. They're very resilient in learning how to do that. And some children can even use the N95 masks. Some of the N95 masks do come in smaller sizes that fit children's faces better. Not all children can tolerate them because they may be more difficult for them to breathe through, but some children can. And the CDC just had a study released last week that showed how well the masks work, that the cloth masks reduced infection rates by about 50%, that the standard surgical rectangular disposable masks reduced infection rates by about 70%, and that the N95s reduced infection rates by more than 80%. So, we do have more tools available for those children, as well as distancing them from anybody who's sick, and keeping them, when they are in crowded situations, either indoors or outdoors where they can't social distance, to make sure that they're masking.
And I would just add that what we've seen works really well, and it's really kind of just been incredible, is the cocooning, getting everyone who's around them vaccinated. We weren't seeing a lot of infections in this age group until the Omicron wave, in the childcare setting, because we had such high vaccine uptake in the instructors and staff at the childcare settings, and the parents. So if you are able to decrease community transmission, number one, so, when we have low rates of community transmission, they have less opportunity to get infected, and then to really just surround them with everyone who is vaccinated. So that includes a lot of the 5 to 11-year-old siblings, and, everyone else, parents, aunts, uncles, grandparents, etc.
I want to expand our conversation about vaccines to include some of the other children also. So as they're working on gathering data for the 0 to 5-year-olds, there is some evidence, and I hear from patients quite often that they want to space out their vaccines a little bit more than the 3 weeks that are recommended by the manufacturer. What are your thoughts on spacing out vaccines between dose 1 and dose 2? And is there any evidence that this does provide better immunity for the kids?
With other vaccines, when you space out the doses in the schedule, you get a better immune response. There was also some evidence that the CDC looked at 2 weeks ago that suggested countries that use the vaccine with an extended interval between the first 2 doses, that there were lower rates of side effects as well. When the pandemic first occurred, of course, the priority was getting people immune as soon as possible. So it made sense to give the doses very close together to get that immunity boosted up there as fast as possible, because we were in such a public health emergency. I think over the next few years, we're going to fine tune the vaccine schedule. Right now for adults, we're talking about the first 2 doses as being primary and then having another booster. But I think in all likelihood, it's going to be a 3-dose primary series with then maybe yearly or less often boosters is what we're going to see. But if you think about the history of vaccines and when this all happens and when we get the data and when we can actually say what's going on, look at pertussis vaccines, which for about 60 years, we were using basically the same vaccines until the acellular vaccines came along. And the same with influenza vaccines, where really the technology and the approach didn't change much until the past recent years, when for older individuals, we've had adjuvanted and high dose vaccine available. So we're just at the beginning. I do anticipate that the schedule will continue to evolve. Right now, I would recommend people follow the vaccine schedule. If you extend the interval, the one risk with that is that you might remain vulnerable after just 1 dose of vaccine. If you have very low rates of transmission, that would be a more reasonable thing to do. If during the peak of the Omicron surge, I would say don't wait. You don't want to wait. You want to get as much protection ASAP. So don't wait. But I think, if parents want to wait, I just want them to get vaccinated. That's the most important thing to me. Get that first dose in there, get that second dose at some point in there. I'm happy with that.
Right. Another question or concern that we've been hearing a lot is from families, oh, I just had COVID. Why do I need to get my booster now? Aren't I protected from COVID? And especially during Omicron, when so many people, unfortunately, actually got COVID, this question comes up again and again. How do you respond to that?
I don't mean to be hogging all the answers, but I know that Dr. Yeganeh is going to talk more about masks when we get to that, but I'll take a shot at that one too, which is that we know that that reinfection is rare within 90 days after getting COVID, but reinfection does occur. And so people who are vaccinated after getting COVID have more than 50% decreased risk of getting COVID again, getting reinfected. In addition, people who have had COVID and get vaccinated afterwards, they have a much decreased risk of getting long COVID afterwards. So there's multiple benefits to getting vaccinated. The immune response in general, the immune response following vaccination is more consistent and is stronger and longer lasting compared to the immune response following infection. There's a whole host of studies out there, and they do have different results. There's a handful of studies that show that infection results in better immune response. But if you put them all together, and the CDC has done that on their website, they've evaluated more than 80 studies, and the preponderance of evidence shows that immunity is better after being vaccinated than after getting infected. So you can get vaccinated as soon as people have recovered and that they're no longer considered infectious. Since reinfection is rare within 90 days, there's no rush to get vaccinated. Some people do wait that full 90 days before getting vaccinated, but anytime after they're recovered and no longer infectious, they may be vaccinated.
Yeah, and I just wanted to add, the one thing we do know, there is a lot of, data out there about what's better, reinfection, which vaccine. We do know that it's safe. Like that data is out there, that it does seem to be extremely safe to get vaccinated after having infection. And this was actually a subset of patients that were looked at in the 5 to 11-year-olds, where they looked at individuals who had positive serology, so previously infected in the trials, and they looked to see if it was safe, if they had more side effects, and they didn't have any more of the side effects, which were minor in most of the children, of just pain and fatigue, and also it seemed like they had better immunity. So again, I would say that this is an absolutely safe thing to do, and if anything, it will improve your immunity even more.
I've had a lot of pushback from some families who are somewhat reluctant to get vaccinated because they had COVID in the past. And part of their argument is that should be considered for some immunity for purposes of, going into restaurants and what have you. And I understand that having COVID once is not providing you great immunity, but there have been some studies out that showed that you guys just talked about, that getting vaccinated after you have COVID is quite protective. Do you think it's reasonable, or will we get to a point where if you had a documented case of COVID and then say one vaccine afterwards, that we might consider you fully vaccinated for public health purposes, or will we continue to have those people get 2 or 3 vaccines after their infection?
Yeah, I think the immune response following infection is less consistent and less reliable compared to vaccination. So I don't think that we're going to be counting that as a vaccine dose, for example. But I think we will continue to count infection, and since reinfection is rare within 90 days, there will be that window of 90 days where, for example, when there's programs for school or other where kids are being tested on some routine basis, that maybe they won't be tested during that 90 days, that they can opt out. So I think those are reasonable accommodations for recent infection.
How about for children under 6 months old? What can we do to protect them, as there currently aren't any vaccines in clinical trials? And do you have any idea when there might be a vaccine under development for them?
Yeah, so what we can do for them, as Dr. Yeganeh has mentioned, is cocooning is excellent. And then vaccinate the mom. Vaccinating the mother is really good for her health and the baby's health. Having COVID during pregnancy increases the risk of the mother being hospitalized, being in the ICU, being mechanically ventilated, and leading to worse birth outcomes as well. So COVID vaccine can lead to a healthier pregnancy and delivery. And in addition, the antibodies are passed on to the child depending when vaccination is done. We don't have evidence yet that the antibodies protect the child, but theoretically they should. And then the cocooning is an excellent way of doing that. I don't know that we're going to have vaccine for less than 6 months of age. The immature immune system is a challenge at that age. For example, we don't have influenza vaccine for less than 6 months of age. It's safe. There's few side effects when you give influenza vaccine, but the immune response just isn't very good. So it needs to be studied, but we'll see if that's feasible or not.
I would also like to draw everyone's attention to the recent MMWR that came out, I think on Tuesday, which actually really did show that there was vaccine effectiveness if you did vaccinate the mom. They looked at, I think, infants in 20 hospitals in 17 different states and looked at hospitalization rates in the case controls trial. And they estimated the vaccine efficacy of vaccinating the mom was about, I think, 60% overall, and then up to 80% if you vaccinate the mom in the later half of the pregnancy. So it does seem like very similar to influenza, similar to pertussis. You can vaccinate the infant by vaccinating the mom during pregnancy. And again, re-emphasizing how important it is to get our pregnant, persons vaccinated during the time of pregnancy or even before pregnancy. We are seeing much lower rates of vaccination in general in our pregnant population. And this is a really, really amazing opportunity to protect not only the mom, but also the baby.
We've been vaccinating 5 to 11-year-olds now for, I think, over 3 months at this point. And we're recommending boosters for adults 5 months after their second vaccine. So we're coming up to that. Do you guys know of any data that would suggest whether these 5 to 11-year-olds will need boosters, or is the fact that they have just such robust immune systems potentially mean they will not need the boosters that adults and older children need?
I think the key word that you mentioned in there is data, and I haven't seen data on that, but we'll need the data in order to inform us to make those decisions in terms of those guidelines, to see if there is increased rate of breakthrough infections, and more importantly, it's not just breakthrough infections, but do we have increased rate of breakthrough infections that are serious that lead to hospitalization or even death? That's the most important metric that we need to follow, because a breakthrough infection that results in mild outpatient illness that a kid misses a few days of school, we can live with that. But what we don't want is kids being hospitalized because of these breakthrough infections.
I wanted to touch a little bit about on the governor's plan, the mandate for schools and vaccinations in schools. Dr. Yeganeh, can you talk a little bit about that, and also how providers can support the schools and the families with these new recommendations?
Yeah, I'd be happy to. I think Rob brought a little bit of it into his slide, so please jump in, Rob and Nisha, if you have additional information. But like Rob had mentioned, in October 2021, the governor did issue a regulation to add COVID-19 vaccine to the other vaccines that are required for in-person education for K through 12. And so this would take effect after full FDA approval of the vaccine, and it would be in a staged way. So once we get full approval for the vaccine for those who are 12 and over, it would become a requirement for the 7th to 12th graders. And once it would get through full approval for the 5 to 11-year-olds, then it would be required for kindergarten through 6th grade. So there are two different deadlines. So you would make it a requirement starting on July 1st. So if we get full licensure of the Pfizer vaccine product before July 1st, then it would go into effect next fall. Additionally, like Rob mentioned, there is the mandate, or the legislature that has been introduced by Senator Pan, and he this actually includes preschools, it includes daycare centers, so it's a little bit more comprehensive. And this legislation also gets rid of personal belief exemptions. So the only exemptions would be for medical exemptions. And again, this would just be adding COVID-19 to the long list of vaccines that are currently required for people to attend in-person education. Of course, trying to keep everyone as safe as possible because these are infectious diseases. So those are the two different things that are in the near future, hopefully. We do have some school districts in Los Angeles County and actually in California who have had vaccine mandates, so districts can make that decision. And we have, I would say, many of our private schools who've also created mandates for their student population. And in general, we are finding that in areas that have these mandates, we are seeing less outbreaks, less transmission. So it is really doing an amazing job keeping the schools safe and open for the children. I would say in Los Angeles County, most of our outbreaks are still in elementary age school children because we have low vaccine rates in that age range, whereas we have relatively high vaccine coverage for the 12 to 17-year-olds.
Can I ask you, since you're involved with the immunization work in Los Angeles County, two things that Dr. Schechter had showed. One was that the vaccination rate for children, particularly the 5 to 11-year-olds, are very, very low in California. And the humongous disparity that we're seeing between zip codes, which I imagine you're seeing in LA County. If we're looking at mandating these vaccines for school, I imagine that 65% of parents aren't hesitant about getting their children vaccinated. Probably a large chunk of that is due to access issues or other issues getting the vaccine. Do you have some plans in store for how you can vaccinate the other 65% of people, the people who aren't hesitant, but for access and to help with disparities?
Yeah, so I think there were the early adopters, the people who were lining up to get their children vaccinated the minute the vaccine was available. And that was a very easy time for us because we just had to make sure the vaccine was available close enough so that they had transportation. So we've been doing a lot of work with school-based vaccine clinics because those are very easy for people to get to, especially elementary age schools, because they're very much in the community. Most people can, walk there or have easy access to them. Now we're kind of entering that phase, that middle third that Rob showed in his slide, where people are kind of in the wait and see, have questions, and they really want to talk to someone they trust about the vaccine. They want to talk to their pediatrician. They want to talk to other parents who are struggling with the same decision. So we're really moving into working more with community-based organizations. We have a parent ambassador program. We have a student ambassador program. We're doing a lot of training of trusted, people in the community because they don't want to hear from us. They've heard from public health enough, I think. They really want to hear from people that they trust. And our goal is to make sure that we have as much information for these individuals and to be able to answer any questions and address any barriers they have in getting information about the vaccine to their community. So that's kind of our method right now. The last third, I think, is the most difficult. And that's kind of what we saw when we had the LAUSD mandate, was that those individuals really, really had a lot of concerns. And in that situation, the things that actually worked were, again, kind of knocking on their doors and talking to them and seeing why they had hesitations, and really trying to work with them one-on-one and meet them where they were and provide information. So that does take several visits. It takes a trusted relationship, and that does take a little bit more resources. So I think this work will be ongoing for a long time.
One question that came in the chat is, if we're going to mandate the COVID vaccine, is there a possibility that this could be extended to annual flu vaccination?
Yeah, I think that's a fair question and a discussion that is worth having to see if we want to do that for public health purposes. The influenza has been around for a while. I think the issue with influenza that makes it a little bit different is that the COVID vaccines appear to be much more effective preventing COVID than influenza vaccines are at preventing influenza. So I think that's one difference. And there's other differences too, but I'm sure that there would be a robust debate about that. I think that's a very fair question to ask.
Since we were talking about mandates before, we had a question come in from before from a school nurse who was concerned that they would be inundated with exemptions, medical exemptions, based on the fact that people had COVID and would use that as a specific medical exemption. For example, children who have chickenpox will write medical exemptions for them to opt out of their varicella vaccines. In the current legislation, there's nothing that says you can't do that. Do you anticipate this being a problem? We've already talked about it's not appropriate, but do you think there needs to be something written into that bill to make something like that not happen?
Yeah, I guess it just depends on how the discussion goes, because, clearly chickenpox is different than COVID, and chickenpox, theoretically, the vast majority of people get it once in their lifetime. And then they're immune for the rest of their life until their immunity wanes, and then they can get shingles or zoster. And that's completely different than COVID, which is a respiratory infection where you get it, you lose immunity, and there's different strains that are evolving all the time. So it's really different. So giving an exemption for recent infection, really that would be appropriate. With our current understanding, that would be appropriate to have an exemption for 90 days. That would be safe for public health purposes, but not longer than that. But yeah, the exemption issue has been very controversial in California. A lot of the people are unhappy about that. A lot of parents are unhappy about that. So I'm sure that will generate robust debate. The one thing that I would prefer is not to have any backsliding on our immunization policy in California.
And I would just say, from schools who have kind of gone through this, it has become logistically very difficult to start the clock and, with high transmission rates, to figure out who is due from their vaccine when. So that is something that will have to be kind of figured out as we get more and more into closer to that date. I don't know if Rob and Nisha have any comments to make about the mandates. I know that they've also been looking at this.
I would say the policy questions you're describing are all under review, and there should be more information as that clock starts ticking with the FDA decision about the vaccine. Then we'll be getting out a lot of information about these policy options around exemptions and the mechanics of the requirement for families, providers, and schools.
Okay. I know we've talked a lot about vaccines, and this isn't really a mask COVID conversation, but it inevitably comes up. So can you explain a little bit about the change in mask mandates and how we continue to protect ourselves?
I know Dean had said that I'm the mask expert, but I'm actually not. So I will try my best, and please jump in. Currently, the changes that have been made is that in California, from my understanding, if you're fully vaccinated, you no longer have to mask indoors. This does not extend to several settings. So if you're in a healthcare setting, if you're in transportation, if you're in skilled nursing facilities, if you're in schools, you still are asked to mask indoors. So that is the change is for California. Now, local jurisdictions can make different rules. And so for Los Angeles County, we are not abiding by that. We're waiting until transmission goes lower. So we are still asking everyone to mask up. And I think we're joined with by a few other counties who are also continuing to do indoor masking. I think what we've heard is that on February 28th, there will be some reevaluation of the need for masking inside schools, and the decision will be based on COVID-19 case rates, hospitalizations, child vaccination rates, and just national, looking at variants and what kind of trends are happening in other parts of the country. A lot of other parts of the country are removing their mask mandates, and some parts did not have mask mandates. So we'll be looking at that data very closely as well as we think about masking. I can say for schools specifically, it's not a question of if, it's a question of when. When will we feel comfortable taking off the mask and indoors? In general, everyone who's worked with schools, from the public health department, and I think many people on this call do think that masking has an enormous effect. We know that our case rates in schools have been far lower than what we're seeing in the community. We know that schools have been extremely safe. So children in school have been safer than children who are not in school all throughout the pandemic. And I think a lot of that has to do because there's really high compliance with masking. But we do believe that it is going to be a point where we will remove the mandate and that it might affect transmission, and the things that will make our schools continue to be safe are ventilation, vaccination, and really, the being able to access testing in a timely manner and isolating individuals who are infected. So that's all the information I really have. The other question that comes along with this is when would we mask again? So when will we reinstitute masking? So we're thinking of off-ramping right now, but would we bring it back at some point? And I do think that that's a really important conversation. And again, looking at things like healthcare capacity, making sure that we are, a new variant, if we're seeing increased transmission, those are reasons to potentially consider reinstituting masking to prevent, schools from closing down or being affected in such a way that they could not operate and offer everything that children need to develop appropriately. We kind of saw that with COVID-19, with the Omicron surge. A lot of schools had problems with staffing, and so we really want to keep schools open, and that's kind of our guiding principle, is keeping them open and safe.
Someone had asked a question about how it was actually been kind of nice over the past 2 years, largely due to masking, that we haven't had a lot of influenza in our communities, and wanted to know whether we think that even if COVID went away tomorrow, whether we still might encourage masking during outbreaks of other diseases. Will we use this public health tool more?
And we've discussed this a lot. We haven't seen pertussis. Usually we get these big outbreaks of pertussis when schools reopen. We haven't seen that. We haven't seen a death from influenza. I mean, these are really important, pathways for us to understand how disease transmission works and how important masking can be. I don't think we're ever going to ban masking. We're more likely going to allow everyone to mask when they need to, but there are probably going to be times when we see increased transmission where we are going to potentially ask everyone to mask up again. So those are my little thoughts.
Yeah, I mean, in the US, every year, in a normal year, 100 kids die of influenza, 150 kids. In the 2020-21 influenza season, 1 child died in the US from influenza. So it's incredible. And that's due to all the lockdowns and the masking. And as many people are aware, many Asian countries, it's like normal for people to mask in public during respiratory virus season. I mean, it works. It really works. I'm a big fan. I don't like getting sick. I plan on continuing masking. I hope other people do too. But obviously, I think it's going to be a personal choice and not a mandate.
Before we close, are there any final messages that you want to be sure to get across, that important messages about vaccines for children?
I'll just mention the one objection that I hear from parents so much is that they're worried about the vaccine because of what they've heard about myocarditis, the inflammation of the heart. And what many parents don't realize is that the rates of myocarditis with COVID or with MIS-C, the multisystem inflammatory syndrome in children, are way higher than the rare case of myocarditis that's associated with vaccination. The highest risk of vaccination is in young males, 12 to 29 years of age. It's about 1 in 14,000. And that's the same as the chance of being struck by lightning in one's lifetime. So it's not very common. And the risk of getting myocarditis is about 6 times higher from COVID-19 infection at all ages. So if parents really care about preventing myocarditis and making their kids safe and having their kids' heart safe, the thing that they can do, the best thing they can do is get their kid vaccinated with COVID vaccines. It's much better for their heart than taking their chance with COVID or MIS-C.
I think the only other point that I would like to make is that what we've learned from COVID-19, I think the pandemic, is that we're only safe if everyone is safe. So really focusing on the inequities in our approaches. We in Los Angeles County know that there's certain neighborhoods that have been much harder hit by the pandemic. They've had more cases. They've had less access to therapeutics. They've had less access to vaccinations. And really, this is our opportunity to address that and try to figure out ways to work with communities to make sure that these health inequities and are addressed and recognized, and that looking at the social determinants of health and really thinking about health in a broader context. So I think about this a lot with pediatric vaccinations because the inequities in pediatric vaccination are really stark, and it's hard to see because we know that these are the communities that have experienced the greatest loss with the pandemic, and just addressing it in a really holistic, thoughtful manner.
So we are just about out of time. So I want to thank so much Dr. Yeganeh and Dr. Blumberg. You guys were amazing. We really appreciate all the information you gave us. Thank you to Dr. Schechter also for setting the stage. And please check out MyCalVac so you guys can be connected to try to break down those disparities and start giving vaccines in your community. Just a few things before we close. You guys will be receiving an evaluation at the end of this webinar. It'll pop up on your screen. It should just take a few minutes. We really use those evaluations to figure out where we're going to go with this COVID conversations and what our next webinars will be about. So please fill out that evaluation. It's very helpful to us. Second, we will be doing this monthly or every other month or so until COVID is gone. So that might be forever. But stay tuned on social media and on your email. We will let you know who our next speakers are. We're thinking about doing things potentially about testing, potentially about off-ramps and on-ramps. So lots of other things that are in the fire. And finally, thank you guys so much for your support and your participation. We have done a lot of these, and you can find all of our previous COVID conversations on our YouTube channel or on the website for the California Immunization Coalition at immunizeca.org. Thanks to Dr. Pannaraj, as always, for doing this with me. I hope you guys learned a lot tonight, and we look forward to seeing you in the near future. Thanks so much.